Okay, well, it's confusing because it looks identical on my computer, right? But all right, so I guess we've got a goodly crowd here. It's 4 after, so we will start. How's that? And I'm going to go fairly rapidly through the slides because there's a lot of them. But you'll have the slides afterwards, so you don't need to scribble down the references. They'll be available to you afterwards. So this indeed is me. And I have no conflicts of interest for this presentation. And then I provided already this paper, which is a good summary. I'm not going to really reproduce the paper here, but it's a good summary of what's going on in the treatment of tuberculosis. And if you're looking to build your own TB library, then the references in that paper would be a great place to start. So here are your tax dollars at work. This is the annual slide set from the CDC. This one was produced last summer. They just released the preliminary data on TB Day on March 24th. And the 2021 slide deck will be available hopefully this June. So if we just look at a sampling of the slides from the CDC, then what we can see is that from around 1953, when they started tracking it down to around 1983, there was a pretty steady decline of 4 to 5% a year. Then it plateaued. I got into the TB game around 1988, and then immediately the rates started going up. So I guess that was my fault. In addition, besides my fault, the TB centers around the country were already dismantling their TB control efforts because they were essentially declaring victory at halftime. And no one had anticipated the impact that HIV was going to have on the rates of TB in the United States. So the rates shot back up to around 27,000 cases, or an incidence rate of about 10.4. And only with the expenditure of billions of dollars have the rates and the total number of cases dropped to between 7,000 and 8,000 per year. Now, let's see if I can get this to advance. Okay. Now, if we look at the death rate, it looks like it went too far. There we go. So I like this slide because it's got on the left y-axis the number of cases, and on the right y-axis the incidence rate. And you can see in 93 the high number of cases and the steady decline. 2020, because of COVID, the numbers are all messed up, and it has rebounded to about 7,800 to 7,900 cases for 2021, and they're still parsing the data, but that's an estimate. Now, this is just to serve as a reminder that TB still is a lethal disease, though it's been relatively flat in the United States, around 500 deaths per year. And arguably, a number of these patients show up to care very late in the process, and there's not a lot that can be done at that point. Globally, there's somewhere between 1.2 to 1.5 million deaths from TB annually. So just bear that in mind. If you're doing work in other countries, the death rate from TB is much higher. Now, if we look at the incidence rates across the United States, the newest states, Alaska and Hawaii, have the highest incidence rates, but they have relatively low populations. So if we move to the absolute number of cases, we see that California accounts for almost a quarter of all the TB cases in the US. About half of that number show up in Texas, followed by New York and Florida. So, hey, go Gators, we're in the top 5. Now, people might say, well, it's those, liberals in California that are messing everything up. And I would disagree with that statement because you have to consider that it's a huge state. So if we look at a comparable landmass on the eastern seaboard, it would go from Pennsylvania down to Florida. And the CDC does account for that, and they call it the South Atlantic area with about 1,200 cases. So California still has more, but not a dramatically larger number. California also has 2 other things. It has a land border with Mexico, which the eastern seaboard does not have. And it is a major portal of entry for people arriving from Asia, where the rates of TB are higher. So if we look at origin of birth as the variable to consider and we look at the greenish bars, that's where you see the dramatic drop in the number of cases in the United States, from around 17,000 down to, a 2,500, 2,400 cases by 2019. So this is where the TB control efforts in the United States can have a direct effect. The blue bars, while they did drop some, they haven't dropped a whole lot, and they've been pretty flat for a number of years. So these are people that are arriving either with latent infection, that's the usual case, and then they go on to have active disease. And it's hard to control TB in other countries, obviously. It's their responsibility, not ours. Though there have been significant efforts given towards trying to test people before they emigrate to the United States. Now, that assumes that they're going through the usual vetting process and the legal process. If they come in otherwise, well, they're not going to be screened. So where does that leave us? If we look at the US born rate, it's 0.7 per 100,000 cases, or 7 per million. A common definition used for the elimination of a disease is less than 1 per million, or using these kinds of rates, less than 0.1 per 100,000. So for the US born population, that's an actual possibility in the not too distant future. But the rates for the foreign born are 1.5 orders of magnitude higher. And that's something we don't directly control. So it's not going to go away anytime soon. Now, I like this slide because it's a good test of optics and what people's eyes are drawn to. And so this big bracket here really captures your attention and says, oh my goodness, a third of the cases occur in people that have been here for more than 20 years. That is true. But if you only have $1 to spend on $3 worth of work, then you're going to spend it right here in their first year in the United States, because that's almost 10% of the cases. And if you had $2 to spend, you'd spend it on the next couple of years, because that's another 5% plus 5%. So 20% of the cases are going to occur in the first 2 years of arrival to the United States. And these people here that have been here for 20 plus years, they're part of the fabric of the country, and they're going to be relatively hard to find at this point. So again, TB control, and if you're going to look to use the treatment of latent infection, the early arrivals from foreign countries, that's where you're going to spend your money. Now, if we look at who within that group you might be focused on, almost half are patients or individuals who come from Asian countries, namely China, India, Vietnam, and the Philippines. So if you have a person from one of those countries in your clinic, and they have signs or symptoms consistent with TB, you should be definitely thinking TB in that patient population. Now, if we turn to the US born population, African Americans constitute roughly 12% of the overall US population, yet they have 36% of the TB, or 3 times the expected rate. So again, if you had $1 to spend on $3 worth of work, you'd focus your attention in that population, because you could make the biggest difference in the total number of cases in the United States. I love this slide because it's both good news and bad news. The good news is we're more or less at the national goal of 95% of the patients completing treatment. The bad news is the big, tall, black, dark blue, rather, bars says completed in less than a year, or at a year. But RIPE is a 6-month regimen. Homer Simpson says, "Doh." So there's a number of reasons why people don't complete their 6-month regimen in 6 months. And I actually asked the CDC and Tom Navin, who's now retired, twice to drill down on that. And what he found, and the same thing in 2013, only about 1 in 5 patients completes treatment by 6 months. And it takes 10 months until you get 3/4 of the patients completed treatment. And as noted on the previous slides, about 12 months until you get close to 90%. Now it's a little over 90% done by that 12-month mark, and a few more patients being treated out to like 16 months in order to get that 95%. So part of it is that, people have adverse reactions and they have to stop treatment, or they move, or they abscond from treatment, or they have some other, family or health intervention that they have to deal with. And so they have interruptions. But a big part of it, I think, is that we're giving the wrong doses. So we're going to talk about that. Right? Just to note, in the United States, we do not currently have a big problem with multidrug-resistant TB, which is resistance to at least isoniazid and rifampin. Now, when I was earlier in my career, it was around 500 cases, so that was very worrisome back in the early 90s. And as mentioned, billions, literally billions of dollars were spent to drive this down. And then now we have roughly 100 cases annually in the United States. Now it says no previous treatment or no previous TB for the majority. So these people were infected with an isolate that was already resistant, or at least as best we can tell. Their initial isolate in our system is drug resistant. Almost all of these cases are patients who are born outside of the United States. And last but not least, on epidemiology slides, I'll just point out that we still have a rate of about 5% of TB patients who are co-infected with HIV. And it's probably higher than that still in Florida. We may be still number one for co-infection. So the moral of the story is if you see a TB patient, you have to test for HIV. If you see an HIV patient, you have to test for TB. Now, because the focus of the talk today is on treatment, I wanted to set the stage by identifying who we're talking about, and now we're going to talk about the treatment. So, as you know, latent infection is when your immune system recognizes that you've been infected, but you have no signs or symptoms of any disease going on. Now, it's possible that you have subclinical disease that can't be detected with current tools, but we'll just use the standard dichotomy for the moment just for simplicity. So you either have active disease or you're latently infected. Now, the standard treatment for many, many decades was isoniazid, and preferably for 9 months, though 6 months does work okay. Now, and people have tried to apply intermittent, directly observed treatment as well, though the data for that are much less. A lot of these studies were done by George Comstock in the 1950s and the 1960s. And keep in mind that rifampin wasn't available until the 1970s. So George picked the best drug at that time. But isoniazid, while it has great early bactericidal activity, in other words, in the first few days of treatment, it can reduce by 10% to 90% or even 99% the number of log phase growth organisms in a patient. And that's how you make someone smear negative and take them out of respiratory isolation. However, if you really want to sterilize, prevent a relapse, rifampin is a much better drug. So rifapentine is cyclopentyl rifampin, and so it's going to do pretty much what rifampin does and vice versa. The 3-HP regimen that many of you are familiar with is giving once weekly INH and rifapentine for a total of 12 doses or 3 months. There is a newer regimen that has been studied in HIV positive or co-infected patients, and that's daily rifapentine and daily isoniazid for only 1 month, and it was very effective. Now, you may argue, well, if it works in those patients, it would certainly work in people with a better immune system, and that's probably true. But you may be old enough to remember when that assumption was made regarding the PZA rifampin regimen. It worked great in the HIV and co-infected population, but when transported to non-HIV patients, they had an unacceptable and sometimes fatal incidence of liver toxicity. So it's hard to think of isoniazid as liver protective, but it seems that INH rifampin PZA is safer than PZA rifampin for reasons that aren't really clear. We tried to study that as well as others and couldn't come up with a reason why adding the isoniazid to the rifampin and PZA made the latter two safer, but it seems to be the case. Now, this is the reference just for your convenience. And again, you'll have the slides afterwards. So this is the study from 2019 with Sue Swindells and Richard Chason or Dick Chason and the ACTG team that studied this. Now, Rifampin, as mentioned, is a great sterilizing drug. It treats log phase growth organisms, somewhat to the acid phase, and certainly the non-replicating persisters. So Rifampin gets all the populations and therefore is able to prevent post-treatment relapse, and that's the definition of a sterilizing drug. Now, 4 months of Rifampin has been shown to be as good or better than the 9 months of isoniazid. Could we go shorter than that? Yeah, but that hasn't been explicitly studied. Could you substitute Rifabutin if your patient is at risk for drug-drug interactions and have a lesser problem using the Rifabutin? Yes, it's logical, but there's no study that actually explicitly proves that. So here is Dick Menzies' paper, also in the New England Journal back in 2018, again, for your convenience for finding it to look at it if you wish. All of this, I believe, is summarized in the 2020 release by the CDC. I'm not going to unpack this document now, but again, it's available for people who need to use this. Now, what if your patient has suspected MDR-TB? What do you do then? Well, there's no really good controlled study at this point to answer that question, at least a large one. Many people will use a fluoroquinolone, such as levofloxacin. You could use moxifloxacin, and some would add to that ethambutol. The duration is uncertain. Maybe it's 6 months, maybe it's 9 months. So there's a lot in flux here. Other people have proposed delamanid or pretomanid, and those might be good choices, though pretomanid in particular has a relatively low barrier for the selection of resistance, about 10 to the 4th, 10 to the 5th. And it's thought that you might have 10 to the 3rd organisms if you have latent infection, somewhere between 100 and 1,000. So if that's the case, you're kind of getting close to where it's not impossible to select for a resistant, pre-existing resistant mutant, right? So I'm not sure pretomanid is going to be the weapon of choice. Bedaquiline probably is, but it's not been explicitly studied, though I think there is a study going on right now. So stay tuned. It may be a very good choice down the road. Now, this is a study that we did in the Marshall Islands and on the island of Chuuk in the Federated States of Micronesia. And this was in a pediatric group that was exposed to many cases of MDR-TB. And none of the people who got this regimen went on to have active disease, whereas some people who did not get this regimen did go on to active disease. Well, it's a small study and it's not conclusive. It does suggest that this is a reasonable alternative for patients exposed to MDR-TB that you don't want to go on to active disease, such as children, because they can get miliary TB or meningitis, and you really don't want that to develop. So now to active disease. We're going to set aside any monotherapies for LTBI because TB active disease always requires 3, 4, or more drugs. What are we trying to do here? Well, first, we're trying to prevent the spread of TB. So that's respiratory isolation. We're trying to cure the case, and that's what you do. And finally, we're trying to find where this patient got the TB and to whom they spread it. And that's where the public health department comes in. And that's why TB is a reportable disease. So the standard treatment is RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol. Almost all of the doses that we use are wrong. Why do I say that? Well, first, the drugs were studied by the British Medical Research Council, largely in Hong Kong and East Africa, and some in India, Madras, what was then Madras, what is now Chennai. So in those places, the patients at the time, the 1960s and the 1970s, were much smaller than the average American. The studies had predominantly males, about 70 to 80% males, and the weight was, on average, 48 kilograms or 120 pounds. Now, I myself weigh about 180 pounds or 80 kilograms, and I'm not that big. I'm certainly not, I don't qualify as obese. How's that? So these doses for me are going to be too small. Isoniazid 300 is probably okay in most slow acetylators. It's probably too little in most fast acetylators. Rifampin 600 milligrams, as mentioned by Denny Mitchison, one of the people from the BMRC who developed the regimens, he said it's the minimally effective dose of rifampin. They had a very expensive drug at the time in short supply and thousands of patients to treat. So they gave the minimally effective dose to the maximum number of patients. That was logical back then, but now it's cheap and it's widely available in every country. There's no need to give the minimum dose anymore. And we'll look at some studies where we go up to 40 mg per kg. So again, keep in mind, we're going to add PZA and ethambutol for the first couple of months in most people. So here is a nice summary of, do we give it 7 days a week? Do we give it 5 days a week? Do we give it 3 days a week? Do we give it 2 days a week? What should we do? And I'll just read this. In conclusion, the current review suggests high levels of evidence for using daily schedules in standard TB treatment regimens, especially in the initial phase, in the presence of cavitation, isoniazid resistance, and advanced HIV co-infection. It corroborates prevailing understanding of pharmacokinetics, pharmacodynamics, and mycobacterial persisters, and supports exploration of rifapentine-containing regimens in higher dosages and frequencies. Right. So this is a 2011 paper, and at the time, rifapentine was approved for active disease, but as a once-weekly regimen, and that's no longer being used, that particular regimen. Now, here's a couple of studies from Martin Boree and the Panacea Consortium. So in this particular study, which is a multi-arm, multi-stage, or MAMS, M-A-M-S, randomized trial, where you're picking the regimens and you're shrinking the number of choices as the study goes forward. In other words, it's like a horse race and some of the horses fall out of the race, right? So in this study, the 35 mg per kg dose of rifampin was safe. It reduced the time to culture conversion in liquid media, and it looked like a promising thing to move forward. The same group produced this paper, which looks at a couple of their studies, and in particular the PK and the PD. And it shows that increasing rifampin exposure shortened the time to stable sputum culture conversion, easy for me to say, and the effect did not plateau, indicating that higher still doses could be more effective. They've gone on to study 40 and 50 mg per kg, and 50 works better than 40, but had a lot of GI intolerance. Now that was 50 milligrams per kilogram, or roughly 3 grams of rifampin given as a single dose. I would posit that if you broke it into half, 25 mg per kg, and 2 doses separated by 2 hours, it would be better tolerated. But that's speculation that has not explicitly been studied. Anyway, 40 mg per kg, or roughly 2,400 milligrams, depending on how big your patient is, of course, should be the starting dose that we use. It's just going to take a while to convince people that's what we need to do. Now, if we look at PZA, the standard dose for many people is 1,500 milligrams. I see smaller than that. And ethambutol, it's going to be around 1,200 milligrams. The one thing I'll mention about ethambutol is that it's renally cleared predominantly, and it also has ocular toxicity, peripheral retinopathy, or excuse me, optic nerve neuropathy. So in the case of ethambutol, what you have to do is make sure you know what the renal function in your patient is, and change the frequency or the size of the dose depending on if the patient has renal dysfunction. So are none of these doses sacred? No, none of the doses are sacred. So here's a nice paper that I contributed to, optimizing pyrazinamide for the treatment of tuberculosis. And the point I'm going to make here is that sometimes we see coming in through our laboratory for therapeutic drug monitoring 1,000 milligram dose. Right? That's not a dose that the British Medical Research Council ever studied. In their studies, if you're less than 46 kilograms, that's pretty small, If you're less than 46 kilograms, you got 1,500 milligrams. Otherwise, you got 2,000 milligrams of pyrazinamide. So what we've seen over time is people, well, I'm going to give less because it'll work just as good and it'll be safer. Neither of those things are true. It's just as toxic and it's less effective. So nice try, but that's why we do prospective studies to get the data. Now, after 2 months, typically we can drop the pyrazinamide and the ethambutol and we continue on, provided that the patient is responding. But I just showed you earlier the CDC breakdown. A lot of people take much longer than 6 months to complete their treatment. If the patient has meningitis, we typically will go out to a year. And if the patient has osteomyelitis with TB, we often go to 9 months. So here's a recent study, and I'm going to get into a few of the more recent studies now in the latter part of the presentation to look at where therapy is going. So this is a TB-TC or TB Trials Consortium from the CDC group, the first author being Susan Dorman, who's now in South Carolina, and this was published last year. So what did they do? So they had the control regimen, the standard RIPE I just described, and in one arm, they simply replaced rifapentine at 1,200 milligrams with food to optimize absorption versus the control rifampin 600 milligrams. So that's kind of not a fair fight, shall we say. Anyway, 1,200 rifapentine, and in the other arm, they added 400 of moxifloxacin, all right? And what did they find? So I'm obviously skipping ahead dramatically here. The regimen with the moxifloxacin consistently met the non-inferiority criteria for efficacy under all of the sub-analyses and the sensitivity analyses. That was not true if it was rifapentine with ethambutol instead of the moxifloxacin. It was still good, but it was not non-inferior. So in other words, it was inferior to the standard regimen if you only gave it for 4 months. It would be a great 6-month regimen, but not so great 4-month regimen. But Moxie, even at 4 months, was as good as 6 months of the standard. Both regimens were safe and well tolerated, and I love this part. Rifapentine exposure was the largest and most significant predictor of TB-related unfavorable outcome. The rifamycins and essentially all the TB drugs are concentration-dependent drugs. If your concentrations are low, you're not killing that many organisms, right? So without flogging that any further, and before everyone gets excited about running out and using rifapentine, let's take a look at the two siblings. So here's rifampin, and let's just say that this circular area here that hopefully you can see my mouse highlighting, that's the mouth of the shark, and here's the tail of the shark. And while no one wants to get whacked upside the head by the tail of the shark, if you're being attacked by a shark, you're not worried about the tail, you're worried about the bitey part, the mouth, right? So let's look at rifapentine, which is cyclopentyl rifampin. They took off a methyl group and put this donut on, right? So this is grease. This is a purely aliphatic group of 5 carbons and attendant hydrogens. And so this drug is now very lipophilic and it sticks to plasma proteins. And when it sticks to plasma proteins, it's harder to clear. And so it has a longer half-life. That's the difference. Now, these are both good drugs. How good? It's like 2 different Ferraris, one with a short tail and one with a long tail, the rifapentine on the right. But they're both Ferraris. And better yet, someone else is paying for them, right? So these are great drugs, and I'm not disputing that rifapentine is a great drug, but anything rifapentine can do, rifampin can do. So let's take a look at why people got excited about rifapentine. Well, if you just look at the total concentrations, excluding the issue of protein binding, rifapentine looks like it's beating rifampin. It hangs around longer and it's got a higher Cmax to MIC ratio. also a higher AUC to MIC ratio. But if we take into account that rifampin is between 80 and 90% protein bound, and rifapentine is 97 to 99% protein bound, now we have a different story. And the ratio now favors rifampin. And there's more that comes to this. So again, what's the issue? It's that aliphatic ring that was put on rifapentine and causing it to stick to albumin. Now, albumin is a very big molecule, relatively speaking, and it's around 66,000 Daltons or mass units, or about 80 times the size of rifapentine. So what does that look like in terms that people might understand? It looks like an aircraft carrier, and here's your little rifapentine tugboat stuck to it. Now, tugboats can go up the river, or rifapentine can go inside a Mycobacterium tuberculosis, but it can't do so if it's stuck to the aircraft carrier of albumin. So again, it's only the free drug that can actually go and do the job. So here's a nice study. If it were Elmer Fudd speaking, he would say pharmacokinetics of rifapentine and rifampin in a rabbit. Right? So what did these guys find? They found that in the necrotic liquefied material inside the cavitary lesion known as caseum, if we say rifampin's penetration is the benchmark at 1.0, rifapentine only got about a quarter of the concentration inside the cavitary lesions. That's the problem. Rifapentine is sticking to other stuff and it can't penetrate these lesions very well. And the poor penetration into cavitary lesions has shown up in clinical trials where the patients with large cavitary lesions don't do well with rifapentine. So be forewarned, you could probably do as well as that 4-month regimen if you gave 1,200 to 2,400 milligrams of rifampin instead of the rifapentine. However, that was not explicitly studied in that particular ACTG study. Now let's turn towards MDR-TB, and I'm going to show some of the most recent data for this condition. So until recently, with the so-called BPAL regimen, there was no standardized regimen, and people tried to use susceptibility data and treatment history to compile the most likely effective drugs. You need that careful history. You can put it on a calendar called a drugogram. And you need new susceptibility data. Definitely don't want to just do this on your own. You want to consult with people who see a lot of MDR-TB. And happily here at UF, we have the Southeastern National TB Center. So you don't even have to call. You can just walk in. They're that close. And get an expert consultation on these kinds of complex cases. We use TDM, or therapeutic drug monitoring, to adjust the doses. If you're going to treat somebody with your last best shot, you probably should make sure you're given the right dose. Now, these regimens are going to go typically 18 to 24 months. The newest BPAL regimen, and we'll talk about that in just a minute, can be as little as 6 months, which is comparable to the RIPE regimen for drug-susceptible TB. Toxicity is common, much better with the BPAL and the BPAL plus Moxie regimens. Directly observed therapy, you really got to make sure these people take their drugs. And then sometimes you just have to give bigger than normal doses because the patients don't absorb the drugs. A little bit about bedaquiline. Here's your cliff notes. It inhibits the mycobacterial ATP synthase, so it just starves it for energy, but this takes time. So it doesn't have much of an early bactericidal activity, but it has great sterilizing activity. This regimen is going to change, but the one that was approved is 400 milligrams daily for 2 weeks, and then 200 milligrams thrice weekly given with food. It is a CYP3A4 substrate, so that's why you're not seeing it combined when appropriate for rifampin susceptible isolates with a rifamycin. People are looking, at least in the mouse model, combining it with rifabutin. More on that on another occasion. And QTC prolongation is the main thing we're concerned about, or at least we think we should be concerned about it. Here's the study I was just alluding to, where you can give it 200 milligrams daily for 8 weeks and then 100 milligrams daily after that. and seeing patients are often taking the pretomanid and the linezolid daily, it kind of makes sense to just give everything daily. It's less confusing. Did they get it yesterday? Or did they get it? You just avoid that in the clinic. Everything is daily. Pretomanid, or PA824, as it was known for a long time, it has multiple actions. In the log phase growth organisms, it seems to be a mycolic acid synthesis inhibitor. It probably produces nitrous oxide under the non-replicating persister state. Right? 200 milligrams daily, again, with food, and it's approved in the US as part of a regimen. It's not approved as a single drug. It's approved as a regimen with bedaquiline and linezolid. It's cleared both by the liver and the kidney. These toxicities, it's not clear that this was the pretomanid, because the myelosuppression is the main toxicity of linezolid, and it's probably what was showing up, but it was studied with linezolid, so you get sort of the toxicity of the regimen. Here is linezolid, and unlike when it's used for gram-positive infections, the standard dose is twice daily. It's cleared by the liver and the kidneys, and the myelosuppression and the neuropathies are the main things we're concerned with. So now, two studies. These are both recent studies. One is the Xenix study by the TB Alliance. The slide set's provided by Sala Fareda. And I'll just go through these fairly quickly, and then you can look at them in more detail at your convenience. And the paper is under review, I believe. So hopefully that'll be out soon. So what did they want to do? The Nix study used the BPAL regimen, bedaquiline, pretomanid, linezolid, but the linezolid was 1,200 milligrams daily, and 80% of the patients couldn't tolerate it, which is no surprise. So they wanted to say, well, we're going to use the standard regimen that we found in the Nix study, but then we're going to see if we shorten it to 2 months at 1,200, do the patients do better? Or what if we gave 600 a day, which is used in many countries, for 6 months, or as little as 2 months? And so for the full inclusion criteria, you can go to this clinicaltrials.gov link, and you can get more information about the trial. But it was all XDR and pre-XDR patients using the pre-2021 definition, and patients with MDR that couldn't tolerate their regimen. So what did they find? It's a relatively small study with about 45 patients per arm, 44. Most people had a favorable outcome, 93%, 89%. And you see the confidence intervals because they're relatively small arms. So these are not statistically different, though you would argue that this one is trending lower than the other three, but still really good for XDR-TB, exceptional. Now, if we look at patients with treatment-related adverse reactions, you can see peripheral neuropathy is the main thing that they were running into. And at the highest and most lengthy duration, then 38% of the patients were having peripheral neuropathy. At the lower doses, a lot less, right? And I would argue when you can use therapeutic drug monitoring and keep the trough concentration less than 2, which is what we do here in the United States, then you have very little of this peripheral neuropathy. Optic neuropathy was only seen in the highest, longest duration of linezolid. And then anemia was seen in the higher doses and much, much less at the lower doses. So this regimen here is pretty much what's used in the United States, 600 milligrams of linezolid daily for half of a year, along with the bedaquiline and the pretomanid. So they conclude that all of the arms could work, and that the 1,200 milligrams for half a year is not well tolerated, and that probably the 600 milligrams daily for 26 weeks is the appropriate compromise. Now, another very interesting study is the TB Practical study, and this was recently presented by Catherine Berry. Also, one of her colleagues presented at CROI. So if you have access to CROI, you can watch the presentation on the slides that are, or the sessions that are posted online for this year's CROI meeting. So this is an interesting study where, let's go back. They had 3 experimental arms and a control arm using the WHO standard care. You could see how many tablets that is compared to the study regimens. So it was the BPAL regimen I just talked about with the Xenix study, except they tapered after 8 weeks down to 300 milligrams of linezolid. And to that, they added either clofazimine or moxifloxacin. And this is culture negativity at 2 months. So this is not the final endpoint, but it's an endpoint for the study. And you can see there's a trend that these regimens are better than the BPAL alone. Maybe not statistically significantly so because of some overlap, but nevertheless, this one does seem to be distinct from this one. In other words, adding Moxi makes it better than just BPAL alone. So they went forward in stage 2 with just the one regimen so they could recruit more patients into it. So this is another adaptive study design. And getting to the punchlines here, they had in the control arm, almost half the patients had an unfavorable outcome. Not so much failure or relapse, but just inability to tolerate the duration and the adverse reactions from all of those second-line older TB drugs, right? And you see much better toleration of the regimen in the investigational arms. And then this arm with the moxifloxacin added to BPAL was it met the non-inferiority criteria for this study. Now, if we look at the individuals with the side effects, again, you see almost 60% in the control arm and much less in the other arms. And you could see the risk difference was much improved with the investigational arms. So these investigators concluded that a 24 rather than a 26-week regimen, in this study it was 24, with a backbone of bedaquiline, pretomanid, and tapered doses of linezolid is both safe and efficacious in the treatment of rifampin-resistant TB. The treatment effects were consistent across all subgroups who got the Moxi arm, and clearly the side effects were lower with this regimen. So this is all good news. When I started in TB in the late 1980s, we were using capreomycin, cycloserine, ciprofloxacin because the other quinolones weren't available yet. And we struggled to get people better with MDR and what's now called XDR TB. So these new 6-month approximate regimens are a complete game changer for drug-resistant TB. I'll leave you with this. So this is the newest of the working group on new TB drugs pipelines. There's one in the paper from last year, but this is the brand spanking new one. And you can just see different classes of drugs that are being evaluated. There's various sons of linezolid. There's sutazolid, there's delpazolid, and one that's to be named later. So this is really encouraging. When I started in TB treatment, there was one drug, Rifapentine, that was in the pipeline. And we were using Cipro, but there wasn't really a pipeline. It didn't exist, right? So now there are a lot of people, including the NIH and the Gates Foundation, but not exclusively them, that are funding work in the area of TB. So it's a much more hopeful situation. I'd like to thank everybody in the lab. They're the people that make it happen. So if you get your cefepime concentrations or your TB drug concentrations back, they are run by TJ or Kyung-Mi. Emily has left our lab for IFAS, but she will be replaced by Alvina. And then we have Stacy Stoneberger, Jesse Liu, Yufei Tang, Mo Alshir, and Nicole Moranchik. And with that, I'll say, you look like you could use a beer. All right, I'll stop there and answer questions.
So Chuck, this is Dave Ashkin. How you doing?
I am spifftastic, and how are you?
So I gotta say, as always, an amazing talk. Yeah, Chuck, you're one of the best, if not the best TB speaker I ever heard. So
it's got to be the water. It's got to be the
I
water.
want to shout out to you, and I want to shout out to your lab. But I do want to get on your case a little. Well, it would never be without. I find it ironic all the time that you keep talking about milligrams per kilogram, knowing full well that there's so many other variables involved. And I understand why we do it, because it's simple and easy, but life is not always simple and easy. And I think some of the statements you make, and I know you don't mean them, but some of the statements you make are overgeneralizations. But at the end of the day, as you alluded to, this is not about how much you put in your mouth, but how much is in your blood. And I think a lot of statements are overgeneralized. And I think in order to get to the point we need to, including with things like PZA and Rifampin and Rifapentine, we need to really look at the individual too, and their ability to absorb how much gets in the serum. And I really want to make that point, because what your lab does is at the cutting edge. And I think you're selling them short by not always emphasizing it can't be simple, not, or it can't be as simple as we like. So that's my first point. I want to make one other point, but please, Chuck, go ahead and get on my case. But I will tell you, outstanding as always. It was great.
Well, I guess thank you and blank you. How's that? Anyway, there could be pediatricians watching, and they always think megs per keg when it comes to dosing. So I have to make sure that, I'm kind of speaking to people who think in those terms. And I agree that people ask me, I just got a consultation earlier this week for a morbidly obese patient who has TB, who has a bad combination. And what should the starting dose be? And, should we use lean weight or total weight? And I just say, pick a weight that you're happy with, start the dose, measure the concentrations, and then it doesn't matter what the dose is, because you're modulating it towards a target value that you choose. So in fact, so just for the rest of everybody out there listening, Dave and I have been giving each other a hard time for 3 decades. Why should we stop now?
So let me just further this, because I really do want to drive this point home, because remember, your audience are clinicians, and your clinicians would never, ever, ever dream of giving a drug, let's say like warfarin or the aminoglycosides, without checking the levels. And I think that we have to recognize there's too much variability. So while what we do studies when we look at mg per kg, they're very meaningful for 100 or 1,000 patients. For your individual patient, it's not very meaningful. So it's kind of like saying, start everybody on 5 milligrams of cumin, load them with 10 milligrams of coumadin daily and then put them on 5 milligrams. It would be unfathomable that we would ever not check an INR. And in some of these cases, that's where it's at. That way you could be assuming that the majority of patients will get better. We don't treat majority of patients. We treat every individual patient. And I think, Chuck, that's why your lab and your work over your career has been so meaningful. So I'm not letting you, I'm not letting you off the hook on that one.
Okay, well, yeah, I agree. And, you could pick any number of medications, and you wouldn't give it 10 units of insulin to everybody in your diabetes clinic. You wouldn't give everybody the same hypertensive drug or cancer drug. We individualize drugs for most diseases, and we have readily available feedback tools like a blood pressure cuff. Well, then you know what dose to give because you're checking the blood pressure. You know how much statin to give because you're checking for the lipid panel in your patient. But at TB, tradition is that we just give everybody the same dose, right? So I agree, it's suboptimal.
So one last thing, and then I don't want to dominate, but again, my enthusiasm for your lectures are amazing. But one last thing. So let's just make it really clear, because the other thing that drives me nuts, and I'm going to have to go to my psychologist right after this, because having to listen to you drives me there. But remember, the 4 months of Rifapentine, Moxie, INH was not as good as you said. It was non-inferior. Big difference between not as good, or as good, I should say, and non-inferior. Unlike when you were showing your work on bedaquiline, where it was non-inferior, they were superiorly non-inferior. The regimen caused 3 times as many microbiologic failures. And again, that's not huge, but as a program, we have to take that into account, especially where we can't get enough rifapentine. So I think we got to be careful about when we use non-inferior, that there's 2 ends to non-inferior. There's inferior non-inferior and superior non-inferior. These are inferior.
Yeah. So again, point well taken. I briefly showed the frequency of dosing. The paper was Jacques Rosset and Wing-Wei Yu as the senior authors. And, so this has been, the holy grail. Give it less often or give it for a shorter duration. And the Rifapentine trial is a step in the right direction, but it's not the last step. And I would say that we would be better off, especially for patients with large cavitary lesions, with giving a big dose of rifampin.
Yeah.
It just
Yeah.
gets in better.
We
Okay.
agree. So blank you too.
Okay. Appreciate. I love you too, man. Other questions? I see chat. Let's see if I can open that. Okay. So
There's a question from Jenna Chuck. If you can see that, I'm glad to read it to you. I think Mo may have answered some of the other questions.
okay. So I'm looking. Go ahead.
Would you let me read it?
Go for it.
In certain circumstances, some patients seem to have an intolerance or allergy to rifampin, but can tolerate rifapentine. Structurally, they're so similar pharmacokinetically. Do you have a theory as to why some can tolerate one and not the other?
I would say that it's more likely that people have used rifabutin rather than rifapentine. Okay, so I personally would not feel lucky enough to give rifapentine instead of rifampin because it's cyclopentyl rifampin. The structure, and I was making it a shark, and I said it was the mouth and then the tail. So the area between the mouth and the tail, if you will, on that projection of the molecule, that is substantially different in rifabutin compared to either rifampin or rifapentine. So there are no formal studies. There are case reports of people not tolerating rifampin, but tolerating rifabutin. But if somebody had a very serious reaction, like thrombocytopenia with renal failure, I probably wouldn't go there. I wouldn't try it.
Thank you. Here's another question for you. I hope you don't mind my impromptu moderating.
No, please do.
Since most of the people with tuberculosis live in developing countries in Asia and Africa, is there availability of drug monitoring labs and facilities? That's a great question.
There are developing centers for this. So Scott Hasel and Eric Haupt from the University of Virginia have set up a lab, at least as a pilot project in Tanzania. We are actively working with the TB program in Tbilisi, Georgia. They've just bought themselves a triple quad mass spec, but you don't have to have a triple quad mass spec. HPLC UV device also will work. So, and then Awe, Kwar, and I have talked about setting up a lab in Ghana. So all of these things are possible. Good old HPLC, short of the mass spec, is not horribly expensive. You have to have a reliable supply of electricity. That's a very important thing. And a few other substrates, shall we say, but it can be done. It's been proven it can be done.
I'll just follow that up. We treat a lot of patients with this BPAL regimen, and we rely very heavily on your therapeutic drug monitoring, and knowing that we can keep a trough less than 2 is really correlated well with our patients and reduce toxicity. But we in the US have been able to use it in over 100 patients, and other countries are not able to necessarily roll it out as safely outside of operational research without that lack of TDMs. Do you see any technology in the future where something like a finger stick blood spot or something else could be used to help at least be able to get a trough to check for safety with linezolid in resource settings?
You probably can. I don't remember that Jan Willem Alphenaar specifically studied linezolid. So Jan Willem was in Groningen in the Netherlands for a long time. Last few years, he moved to Australia. So there's a couple of labs in the Netherlands, Jan Willem's in Australia, and maybe a few others. So there's a series of labs globally, but probably all concentrated in fairly rich countries that can do therapeutic drug monitoring. Now, I am aware there's at least 2 laboratories in India that have the technology, but I think they're predominantly using it for clinical trials. And I don't know that they're actually doing it as a clinical service. But I would say, I mean, HPLC came of age when I was a college student. And if you look at the color of my beard, you can see that was a long time ago. So, you know, it's a mature technology. It's not horribly expensive. Mass specs have advantages, and we use mass specs with HPLC with a mass spec detector. But you don't have to do that. So yes, dried blood spots have been studied. They work for some drugs like the quinolones and rifampin. They really don't work as well for isoniazid because it kind of falls apart. Probably true for cycloserine and ethionamide. So it just depends on the individual drug, whether a finger stick, dry blood spot will work or not. All right, well, it looks like we are coming up on the hour. Are there any other questions? Hearing none, feel free to email me with any other questions that you have. Appreciate you taking the time, and have yourself a great weekend. Bye-bye now.